It. Okay, so let's talk about pain and what it all involves. First of all, I think that there's been a change in pain concept, and it's all over the news. Way back when I was going to school, um, pain was subjective, and you did whatever you needed to do to treat the patient's pain. Um, Now we have found ourselves in an opioid crisis. And so now things are changing. And a lot of that is coming through the federal drug um, and alcohol board and really cracking down on opioids and dispensing, limiting, really kind of limiting how much we can give for how long we can give it and those kinds of things. And just really trying to crack down on that opioid addiction. Um, and you know, I think a lot of it isn't maybe so much addiction. I mean, we do have a lot of addiction, but we have a lot of selling. We have a lot of people who are getting opioids and selling it, and just really dangerous because we put a lot of opioids out on the streets, and nobody's monitoring it. And so can put people in really, really tough situations. I think pain is a difficult topic. It's not like a blood pressure. You can't put a blood pressure cuff on and tell me what their reading is. So a lot of it is subjective. But I think we have to exhaust all of our alternative options for treating pain before we just, continue to give pain meds. I really struggle with the fact that, people go in for surgery, and I'm all for treating pain because if we don't treat pain, people don't heal well. So there is a purpose and we do need to treat it. But a lot of times we find in the acute care setting that patients are giving all kinds of pain meds, big meds, fentanyl and morphine and all of those kinds of things, and sent back home um, with hydrocodone for 2 weeks. Well, that doesn't cut it. When you're using morphine and fentanyl and hydromorphone and all the big guns, and then you get sent home on hydrocodone or tramadol, that's a pretty significant decrease in the amount of pain that a person has, and so that increases their pain perception. And then, of course, they need more pain meds. So it's kind of a catch-22. We find ourselves in that box, and how do we take care of it? And how do we manage it? And I think the best we have working in rural America, we kind of have the one up on some people because we know our patients. We know what's going on in communities. We hear the same stuff everybody else hears. And it gives us a little bit better ability to kind of monitor that and to kind of help out with those kinds of things. So different kinds of pains, different types of pain, and the difference between what type of pain it is differs on how you treat that pain, and how we manage that pain. So acute pain is any pain that's 6 months and less. So people who have surgery, people who are in car wrecks, people, so it's that pain that lasts less than 6 months. Chronic pain is any pain that lasts longer than 6 months. Referred pain is so when you have pain, but it's actually somewhere else. So if you think about if you have an appendicitis, and so oftentimes, your appendix is down in your right lower quadrant, but a lot of times people will have pain around their belly button. That's referred pain because that pain is actually, there's a big nerve that runs right underneath the appendix. And so the pain follows that nerve root. And so it's not necessarily in that left lower quadrant until it's too late, or in the right lower quadrant until it's too late. It's oftentimes at the belly button. People who have gallbladder attacks will almost always complain of pain in their left shoulder, and that's because there's a great big nerve root right underneath the gallbladder, and that pain is referred. So referred pain is either parietal or visceral, and I remember it with the letters. Parietal is pinpoint pain. If I can point right to my shoulder, that's parietal pain. Visceral pain is a vague pain. So if you think about somebody who has a colitis or an inflammation of the colon, that is vague. It hurts everywhere. And no matter what I do, it hurts. No matter how I move, it hurts. It hurts everywhere. And so that's called visceral, or it's a vague pain. They can't pinpoint to it. So P and V go together. Intractable pain is the pain from cancer. And so we know that pain with cancer typically does not get better. It gets worse, and it gets worse, and it gets worse. With the exception of people who have brain tumors. It doesn't hurt after a while because that tumor has compressed so much on the nerve root that there's no more feeling. So but most cancer pain, cancer is typically painless until the very end, and that pain gets worse and worse and worse. And I think this is the hardest part because not only are you dealing with a patient who has pain that you are not able to control with no matter what you throw at it, but you're also having to treat family who are sitting around and watching this. Nothing worse than having a loved one that you can't help. You can't do anything to help them. And that pain is so intractable that you can't get a control over it. So we do use a lot of meds. We use a lot of meds. We use fentanyl. We use hydromorphone. We use morphine. So we use big time medications. And those meds are fine because, at the end of life, our job is to make them comfortable and to make things as peaceful as we can. But also important that pain meds suppress the respiratory center. So if I'm giving fentanyl and I'm giving morphine and I'm giving hydromorphone and oxycodone, there's a chance that all of those meds can suppress the respiratory unit and they can pass away. So we just got to be open and honest about how much we're giving and what we're doing and the weight and balance. And most of the time family will say, just give it, just keep giving it. There's nothing worse than listening to somebody cry with pain at the very end of their life. And not a lot you can do about it. So we give them lots of pain. We also usually will mix it with Ativan. And so you're giving pain meds and you're alternating with Ativan during hospice care and end of life care, just to kind of help with that. Also, idiopathic pain. And this is where we don't know the cause of the pain. We don't know where it's come from or what's causing it. So it's really an idiopathic pain, where the physical pain, we can't identify it. And there's people who have that truly, we've done x-rays, we've done MRIs, we've done all kinds of things. But people still have pain. And so we call it idiopathic pain. And that pain is very difficult to treat because you can't treat a cause. You're not treating inflammation. You're not, you don't really know what you're treating. So gabapentin, Lyrica, all of our pain meds, our NSAIDs, our opioids, we're just kind of throwing stuff at a wall and hoping something sticks, is really truly what we're doing with that. Yes. I have my old PowerPoint up. I'm trying to find my new one. Oh. Hmm. Just a second. I'm trying to find it here. I can't find it. Okay. It's loading up here. 1 second. Sorry about that.
Okay.
All right. I'm just going to move things around here a little bit. Okay, so pain is the body's response to distress. It is subjective and it's based on perception. And when I say that it's based upon perception, that's based on the fact that um, what you perceive as pain may be entirely different than what I perceive as pain. Um, so sometimes you can have these. Um, I always get a little bit nervous when these big, strong men come in and they're complaining of pain, because I just feel if they're complaining of pain, then I need to be really, really concerned about it, because um, typically, there's some people who complain about nothing, but then you also have some people who complain about everything. So trying to figure out, um, where people are at or what there is kind of hard. So you have to kind of go based upon their perception of pain or how they see it to be. And sometimes that's not always so easy. I'm saving it to my hard drive so that I can pull it up on my other computer, because I can't see you and see my lecture at the same time. Okay, now I think I got it. Um, So when we talk about pain being perceptive, it's based upon what you think is pain and how much pain you can withhold. So, I think about those old games that we used to play. Maybe you didn't play them, I just maybe did it. But, when people would give you a snake bite, and they'd twist your arm to see how long you could last. Well, I'm kind of a wuss, so I wouldn't last very long, but I'm sure there's a lot of people who lasted a lot longer than I did. So it's all perception of pain and what you perceive it to be, and what your threshold of pain is. Pain is also a protective measure, and that's really what, it protects us to withdraw or to remove from a stimulus that might be causing us pain. So, if you have your hand on a hot stove at some point in time when it's painful enough, you're going to pull it away. And that's the body's sympathetic response to pain, and that's just to protect us as much as possible. So factors that affect pain. So physiologically, age, fatigue, genetics, and neurological function. So if you think about age, people who are really, really young, they don't tolerate quite as much pain as people who, 20, 30, 40. And then people who are older than that, is when they get into their 60s, 70s, they just can't tolerate pain as much as other people. Fatigue, the more tired somebody is, if they're not sleeping, the more pain they're going to have. And then neurological function, people who are paralyzed or paraplegic, they don't have pain at certain parts of their body. I do have it down here. Social, so some people use pain as for attention, to seek gratification. It's also based on your previous experience of pain. If you know it's going to hurt, you think it's going to hurt a lot worse. And then if there's enough support in the home or people to support them. Psychologically, people who have anxiety problems, coping issues, or depression, they perceive pain at a lot higher threshold, at a lower threshold than most people. So one of the things is people who have chronic pain, it's something that you always have to assess with them is, do they have a depression issue that we need to be taken care of, or something that we need to be fixing along with the chronic pain issues. Pain threshold, that's the lowest intensity to cause pain. And then pain tolerance is at the point where people cannot tolerate pain any longer. So if you think about the number scale, pain threshold would be, at that 1 or 2 where, it's there, but not really intense. And their pain tolerance would be when it's getting up to 8, 9, 10, where I can't tolerate it absolutely anymore. So that's kind of where that pain threshold and pain tolerance is at. People who've had, low back pain or, whatever kind of pain for long periods of time, at some point in time, they just stop feeling, their threshold, their tolerance becomes more and more and more, because they're just so used to it. They've just become accustomed to it that pain tolerance will actually get to a point where they can tolerate quite a bit of pain. And so, when those people are coming in too, it's one of those things that you need to set up and take attention to, because if they've never complained about it and all of a sudden they're complaining about it, something's changed, and a workup needs to be done to make sure that we address what's going on. We talked about the different types of pain. I really like this picture of the pain pathway. I think it's that visual for us of how it really happens. So we stub our toe, and pain initiates there. It goes up into the spinal cord, it goes up into the dorsal root, and it comes back down into the ventral root, back down, and and then we perceive pain as to, oh, that hurts. The other portion that I really like about this pain pathway is I think it's a good visual for us where meds work at different levels of this pain pathway. So opioids, they really don't make pain less. What opioids do is they affect it in the brain and they alter how we perceive pain. So they don't make pain go away. All it does is it changes the perception of pain. So opioids really work in the brain, whereas your NSAIDs, like your ibuprofens and your Celebrex and your naproxens and all of those kinds of things, they really work down there at the initial where you initially feel pain. So like down there at the foot, because they're trying to eliminate the bradykinins, it tries to eliminate the prostaglandins and all of those kinds of things, decreasing the amount of swelling and molecular release, and trying to inhibit that so that it stops that pain to really begin with. So things kind of work at a different level. And so I really kind of like the picture because I think it's a good visual for us, but it also helps us, I think, understand where different pain meds work along the route or the pain pathway. So the process of pain is the transduction, and that's the conversion of a noxious stimulus into an electrical stimuli. So let's say you stub your toe, and then it starts that process where it's going to go up to the brain. And so that's transduction, where that initial pain is started, so the stubbing of the toe, and it turns into an electrical stimulus that's going up that nerve root, up into the brain for our brain to perceive it as pain. Transmission is the stimuli that moves from the peripheral nervous system toward the brain. So this is after transduction, now it's starting to move up the nerve root up into the brain. Perception is that experience of pain, and this is where you get your threshold and your tolerance. This is where the brain is beginning to interpret how intense this pain is. And here, it's really based upon how we perceive, how we look at pain. Um, and then modulation is the interaction of the brain and the spinal nerves to alter the pain perception. So we withdraw it, or we begin, we hop on one foot trying to alleviate, any more pain on that. This is how we react to it, how our body initially reacts to that pain stimuli after the brain has conceived it or perceived it as pain. So if you think about, let's say somebody trips in a hole and breaks their leg. Okay. So initially when they trip, when their foot gets into that hole and they twist that foot, that's transduction, because we're converting that stimuli to an electrical pulse or electrical energy. Transmission, it goes up into the brain. Then we perceive that as, does it really, really hurt bad or not quite so bad? So, I think about basketball players and, football players and those kinds of things. After you've been hit so much or you've twisted an ankle so much, a lot of times they don't show a whole lot of pain. But somebody who hasn't experienced that pain before may think it's the worst thing in their whole entire life. So that's that perception of pain. Yep, Kobe?
I remember when I was a kid and watching on the commercials, there was this one like Olympian chick that like dislocated her hip or something like that, but she still finished. She was like a gymnastic person, and she still finished and did all these kind of flips and everything, even with like that major pain in her leg. So, it makes me wonder how people like ignore that and just keep on going.
Yeah, and it's all based upon that perception, how you look at that, and if you're able to channel it differently, if you can mentally channel and, channel that differently, then you can do that. But for some people, they can't do that. I think about people, you talk about, that gal. A lot of people can use imagery, and they can use, those kinds of things where they can go to this different place, and it kind of removes that pain. I think about that especially for little kids when I'm sewing them up. And, I'll be injecting the lidocaine, which is the worst part of the whole process for them. And I can do that pretty easily as long as I get them to start talking about something that they like. Well, let's talk about school, or let's talk about recess, or I seen you outside playing football the other day. And if we can start talking about those things, I can inject, because now I have them channeled on something different, that I can focus their attention to somewhere else. The other thing I think about is I had a cousin who was in the Iraq War, and he um, their Humvee went over a landmine and he was burnt. 80% of his body was burnt. And so he went through a lot of those dressing changes 2-3 times every day. And it's so interesting to hear him talk about it, because the military is really, really the military is, they're very advanced. And sometimes I don't think we think that about them medically, but they truly are. Those guys on the battlefield, we learn a lot from them. And so anyway, he was talking about how when they did his dressing changes, he would put this hood on, and then it was like a game. So he would play it. He put this hood on his head, and then it would be like a video game. And he would play this video game while they were doing the dressing changes. And he would talk about how it really didn't hurt. And it's because they consumed all of his brain pathways with this game, this video game, that they could do something to they could do his dressing changes on his legs, and it really didn't cause him any pain. And so that's really the new thought process, and using these pathways and overloading them so that we can prevent the stimulus of pain. And so there's a lot of research being done on these men and women on the battlefield who have these burns, and how we can circumvent or channel their thought process of pain. Because you can only give so much morphine, you can only give so much meds, and people who have extensive burns, it doesn't matter what you throw at them, it's not enough. But so it's so interesting to hear him talk about how they use this game. And he said you wore this hood and it was a video game that you played while they did the dressing changes and it didn't hurt. Did you have a question, Reggie?
Yeah, actually use that. Um, Something they kind of taught us to use at regional. Um, I did it with a patient that was going through nerve blocking, and he was on the second one, and it was really hurting and stuff. So I had him visualize. See, his thing was his grandson and fishing and all that. So I told him that I was talking to him, he was in pain, and I was telling him that he didn't have to be there. It was his body that's going through that, and to visualize something else. And I got him to fully engage, and he visualized. I told him to visualize him and his grandson on a boat fishing, and what would be going on. And I played this whole thing out like a story to him, and he just kind of calmed down. And then eventually, by the time they got there with the pain meds, he was totally calm, but he was still in pain. So I've actually done that before too. So.
That's awesome. That's awesome that you can do that, and you've been through that, so you know how to talk somebody through that, because that's very beneficial. Did you have something, Joe?
Oh yeah, I was just gonna say, I know a lot of the medical advancements come from the battlefield.
They do. We get so much from them.
My cousin was a PA, and he knows the Vietnam War era. He was a special forces medic, but when he got out, he went through the PA school, and a lot of the doctors we got in here at the IHS came straight from the battlefield over in Vietnam, and they were really sharp, and they had all the latest techniques. That kind of thing. I knew at that time when you tell me these stories that a lot of the advancements came from a lot of them came from the battlefield.
Absolutely. We get a lot from them, whether, it's that in the moment. And I think medics on the battlefield, they're trained to treat what's in front of them and then go from there. Where I think a lot of us who don't work in that area, we get overwhelmed with all the details instead of just focusing on what's right in front of us. So yeah, I think that you're so right. They are so good at that. So conversion of pain, and so this is kind of an important slide to remember, because this will help you with all of the pharmacology component when it comes to pain management. So when we're talking about conversion of pain, there's a prostaglandin release, bradykinins are released, substance P's, histamines, serotonin, and neuromodulators. And so that's how our body perceives pain. These neurotransmitters are released into the body, and it's sent up that nerve route, and that's how our brain perceives pain. So the question is, how do we minimize these things? If we can minimize these things, then I can minimize pain or how people perceive pain. So everybody has experienced a twisted ankle, right? We've all been through that. And it's swollen and it hurts and it's not feeling really well. Well, I know that a twisted ankle is more about swelling, pain than anything else. So if I can get people loaded up on ibuprofens or naproxen or something like that, because it's an inflammatory pain, I can minimize prostaglandin release, I can minimize bradykinin release, and I can release substance P release with just my naproxens or my NSAIDs. So now I have really taken out 3 of the 6 different neurotransmitters that perceive pain. So a lot of times, just treating somebody for inflammatory pain, treating them with the right thing will minimize their pain. Okay? Now, I know my ibuprofen only works for 6 to 8 hours, so they've got to take it, every 8 hours. But I know that if they take naproxen, they only have to take it every 12 hours. I know if they take meloxicam, they only have to take it once a day. So I can get better control over it by just knowing what meds I need to use. Now, histamines, so you have people where histamines are released. So a lot of times when people come in tremendous amount of pain, we'll throw Zantac on board. And Zantac is a histamine 2 blocker. And so by putting Zantac IV, we hit another neurotransmitter that reduces people's pain response. And then serotonin, this goes back to serotonin, it's a neurotransmitter in the brain. And so goes back to that linkage between depression and pain. And we're really working on that serotonin neurotransmitter. And by treating both of those for people who have chronic pain, we can get it will help us get control of people's chronic pain. So I want you to look at these conversion of pain, all these 6 neurotransmitters, and I'm going to give you an example. Okay. So somebody comes into the emergency room and they have tremendous abdominal pain, nausea, vomiting, and pain 10 out of 10. It's intense. It's a stabbing nature. And if it's up in that right upper quadrant, that's gallbladder pain. So the meds I put on board for these people, I give them Zantac, I give them Toradol, and I give them just a little bit of morphine. And within 20 minutes, I've controlled their pain. I've taken them from a 10 down to like a 2 or 3. And that's because my Toradol is working on the prostaglandin and on the bradykinins and the substance P. My Zantac controlled their histamine, and my morphine controlled the neuromodulators that they have going on. So understanding pain, understanding the concept of pain, and giving the right meds is so important. And that's why we just spend we spend a lot of time talking about pain, because it's so important to understand how it's perceived and how we treat it, so that we're not just throwing meds or throwing spaghetti on a wall and hoping it sticks, because that's why we got into the opioid crisis we're in. We didn't treat pain effectively. We just kept giving people opioids. Hydrocodone doesn't work. Well, let's go to oxycodone. Oxycodone doesn't work. Well, let me give you a little bit of morphine. That's where we got into big trouble, because we really didn't treat pain because we didn't understand it. So now we have to go back and re-educate everybody to what pain is. So the assessment of pain, when you're assessing somebody's pain is really the 5th vital sign. So you take their temperature, you take their pulse, you take their oxygen level, you get their blood pressure, but you better be asking about their pain. Do you have any pain? What does it feel like? What is it? All those kinds of questions. So pain is really the 5th vital sign, and making sure that you're assessing that when you're doing their vital signs is so important. Now, their assessment, it's subjective. It's whatever the patient says it is. And so I can come into pain. I can come in and, I probably don't have a very good pain threshold. And so I might think that the little tiny minor things are a big deal. But somebody else can come in and they can tolerate pain pretty well. So pain being subjective, I'll tell you, one time I had this guy come in. He's like, I don't know, 200, 300 pound guy, really big guy. He's a farmer. He works out in the field all day long. Comes in to my ER and he's crying like a baby. He is so diaphoretic. He can't sit still, and he's sweating and he's sweating and he's sweating. I can't even get an IV in him because he doesn't sit still long enough. And his skin is so diaphoretic, I can't get tape to stick on there. But it's pretty typical. He had kidney stones, and that's what happens, I mean, they're awful. And so that's how he presented. So you get the morphine on board, you get the Toradol on board, you get all those meds on board, and then you can control that pain. But you're really focusing on treating what there is and going after those neurotransmitters so that you get better control of pain. The other thing, unfortunately, that we all have to look for, and these are those aberrant behaviors. Aberrant behaviors are drug-seeking, what we call drug-seeking behaviors, people who are looking for those meds. Do they get mad when you tell them that you can't give them the medication yet? How are they acting? How are they behaving? We need to make sure that we're documenting aberrant behaviors. We don't say that people are drug-seeking. We don't say that people are, making big things out of little things. We don't say that. We tell you what it looks like. They're asking for their meds. They are continuously asking for medications early. They get, verbally aggressive when they can't get their medications, those kinds of things. You need to put that stuff in their chart, because do you know the number one people who sue are people who don't get pain meds? Those are the people who sue. So you gotta chart it. You gotta put it in there. If it's aberrant behavior, you gotta chart it, because those are the ones who are coming back after you. Yep, Kobe.
And working in the nursing home setting, um, maybe they're not like addicted, but I see a lot. Maybe that's their last control, like the last thing that they control. Because in the nursing home, I always see right when they can get it, call light on, or it's like 30 minutes early, like I need it, and it's like, I don't think they're, I mean, maybe some of them are, but I think some of them, it's like, this is the last thing that I can control. This is what I have control over.
I agree with you. I think that at that point in time, it truly is. It's a control issue, and and I think you're right, exactly. Um, but those aberrant behaviors, make sure that you're charting them, make sure that you're looking at them. A lot of times in a lot of the computer charting, people will have, when you're assessing pain, they have those aberrant behaviors as a check off, just to check whether you've seen them or not, so that you're putting that in the note automatically, because unfortunately we have to protect ourselves, and that's just the world that we work in. Description of pain, and this is so when we're asking about pain, I grew up with the old cart system. In your book, it talks about PQRRST. So I put both of them on here, but I'm old school, so mine is the old cart system. And so you're talking about onset of pain. When did it happen? When did it start? What was going on when it happened? Those kinds of questions. Second is location of pain. Or does it radiate anywhere? Where does it hurt? And does it go anywhere else? Important questions to know. So, and then duration of pain. Is it constant? Is it intermittent? Those kinds of questions. Character, having them describe it. Is it sharp? Is it dull? Does it feel like somebody's stabbing you? Explain it to me. Explain, is it a burning pain? Have them describe that pain to you, because a lot of times you can start to diagnose what's going on just by a good description of what it is. So making sure that you're going through all these. Aggravating, what makes it worse? What do you do that makes the pain worse? And then relieving, what do you do that makes it better? Does Tylenol make it better? Does ibuprofen make it better? Icing, elevating, anything that you do that make it better. Important, people who have abdominal pain, does it make it better when you eat? Because people who have duodenal ulcers, they eat because the pain feels better when they eat. So that's, you have to ask those questions, because people aren't going to put them together. You got to ask them. And then timing of the severity. When is it the worst? What is it? When is it at the worst? And then the PQRRST. So this is provocative or palliative. What makes it worse? What makes it better? Quality, radiation, region, severity, and temporal factors. So they're the same thing. You get the same questions, but it's a little acronym to make sure that you're running through all of those questions and making sure that you're talking about all of them. A lot of times I diagnose appendicitis just by, I don't need blood work. I don't need an x-ray. Tell me what your pain feels like. I can diagnose an appendicitis off that. I can diagnose a gallbladder just off the description of pain. I can diagnose kidney stones just off of that. So important that you ask those questions and you get to the bottom of it and chart it very, very well. Because a lot of times, nurse, after you do this for a while, you'll pick up on those things and you'll know exactly what they are. But providers will look at that assessment as well, and they can start to narrow down what their diagnosis is just based on the questions that have been asked. So making sure that you're going through that. Those are good test questions. Make sure that you study those. Pain scales. So we talk about Pain being, it's the perception, it's their subjective information. But unfortunately, that's really hard for us to chart, right? They say it's really, really bad. Well, so we come up with scales now because we always like to make things measurable. So we use the numeric scale, which I think is really, it's easy. It does the trick. Rate your pain 1 out of 10. You give them pain medication. You go back 30 minutes later. Now rate your pain. Did you make it better? Did it get worse? What's going on? The visual, and that's for like little kids, whether they're grimacing, whether they're in the fetal position, those kinds of things. So that's that visual scale. Faces is where, the really sad face to the really happy face. And we use that for little kids for them to, say, which one do you feel like? How are you feeling? Which one matches the face that you make? And then you can begin to kind of use that scale for them. FLAC, this is what we use for infants and for neonates. We're looking at their face. Are they grimacing? Are they crying? Legs, we look at their legs. Are they pulled up against them? Activity, are they consolable? Consolable is so important to really make sure that you note that, because kids can be very, very fussy and they can be in a lot of pain. But if they can crawl up on a mom and dad's lap and mom and dad are able to console them, that means that pain, it's bad, but it's not uncontrollable. So parents' ability to console their kids, very important to chart that. And then NIPS, this is just facial, crying, breathing, arms, legs, and arousal. So the FLAC and the NIPS, really we use those for infants and neonates. Faces, and the visual, we use that for our kids. And then the numeric, we use it for anybody who's old, for old, teenagers on up. The next slide, this is your faces for little kids. I think almost every room has one of these in them so that you can use it. Different therapies. What can we use? I talked at the very, very beginning about how we are in an opioid crisis. And so we need to look at what's in our toolbox. What other things are available to us in treating pain other than just throwing more opioids at it? And so there's our pharmaceutical meds, and, yes, they play a role in things, and they can help, but there's a lot of other things. Nothing frustrates me more than when people have been treated for low back pain for years and years and years, and nobody's done an x-ray. Nobody's done an MRI. What if they have impingement that surgery could fix it? Then we fix it. We get them off the opioids and we do surgery and we fix the problem. So a lot of times just doing the right surgery. People who have knee pain and they have meniscal tears, I've seen people with meniscal pain all for long periods of time. You do an MRI, they have a major meniscal tear, they go in, they scope it, and 2 weeks later they feel like a rock star. So making sure that you do the right assessment, you work it up, because you don't know that it's just chronic pain. It could be something acute that has not been worked up appropriately. So make sure you do the appropriate workup. Comfort care. So rubbing people's backs, rubbing people's fingers. Has anybody ever experienced a migraine? What do you want people to do when you have a migraine?
Be quiet.
Be quiet, shut off the lights, put me in a room where nobody bothers me, right? Doing that will help.
I used to get them in high school a long time ago, but my adopted mother, she was the nurse, and she used to just tell me to go lay down, and she'd turn the lights off for me and then give me some Tylenol or something.
And it would make a big difference, wouldn't it? Just being in that, and I tell you, it's maybe my nursing side of me, but there are times that I want to just kick doctors in the butt. When I have a patient who has a migraine headache and I have them off in a room and the door is closed and I have, the lights off, letting them just rest. And they whisk in there and they flip every light on. And it's like, what the hell are you doing? These people have a migraine. Knock it up. So those are comfort cares, treating pain without having to do anything, just changing the environment. And sometimes by doing that, whether, some people, aromatherapy has become a big deal, right? I mean, you don't go anywhere where there's not somebody who uses aromatherapy. And people who do it find it very, very helpful. Whether it's putting lavender on or whether it's, putting orange or whatever the case, for every ailment, they've got something. And so those kinds of things, just changing that, putting light music on, relaxing music changes things. So there's a lot of things we can do for just comfort cares by changing the environment a little bit. We've talked about distraction and diversion, right? That's very, very useful and very helpful. So make sure you're using it. Make sure you use it. Imagery, so taking people back to, a certain time and place. You talked about that, Reggie, taking that patient back to, fishing with his grandson and those kinds of things. Has anybody ever used a TENS unit? Those little electrical, it's an electrical unit, and it has a patch on, and you put it on wherever it hurts them, and you turn this TENS on into a little electrical device, and you just turn it up, and they use it for, 10, 15 minutes. And, so people who use TENS devices, they swear by them, and it really helps them. So, you're treating pain without any medications. You're just using other things. So looking in that toolbox. So important about exercise and getting people physically active again makes a big difference. And if you remember back to the neurotransmitters we talked about, remember we talked about serotonin. Exercise releases serotonin, and it increases serotonin in people's minds and in their bodies. So getting people physically active again will help with that control of pain. Heat and cold, that helps. I am a migraine person that I want heat, but I know people who have migraines who want cold on their face. Everybody does things differently. Sprained ankles, those kinds of things. So just remember, for sprained and muscular problems, it's cold for 48 hours and then heat after that. Chiropractors, they can be very helpful, especially for people who have chronic low back pain and those kinds of things. I was not an acupuncture fan, never had done it. I can't say it was a bunch of hogwash. I just never done it. So, but one of the PAs that I work with, he just took a class on acupuncture, and he had came back and he had to do it on 40 people before he got his license or whatever. So he did it on me, and I tell you, I'm a firm believer that acupuncture can work. So, get people hooked up with that, because it can work and it can be very helpful. And then the other thing is, for people who have that intractable pain, or that idiopathic pain, we're finding that hypnosis can be very helpful for them. So getting them in with a therapist who does hypnosis, and helping them find that cause of the pain can help them a lot with that. So just making sure that we're going back to our toolboxes and not just using one thing, but using an array of things. I know in the IHS systems, what we called pain management at one time, which really wasn't pain management. We did urine drug screens and police people through urine drug screens as to whether they got their pain meds or not. That's not pain management. Pain management is using counseling and physical therapy and dietary and nutrition. And yes, pharmacology is part of it, but getting everybody at the table and managing pain from a comprehensive approach, that's pain management, and using as many of these tools in the toolbox as possible. I just have a few things on here about pain medications, and Bree will go over more in depth about those. This is the World Health Organization pain ladder. So important that you know this, because this is how we determine what we're going to use. Okay, so we always use non-opioid things first. Tylenol, ibuprofen, heat, ice, those kinds of things. We have to have exhausted that. Once we've exhausted that and they're still having pain and we haven't controlled it, then we can begin to step up to things. So then we start looking at our Tylenol with codeines and our Tramadols, our Celebrexes, our Lyrica, those kinds of things to kind of help us treat pain. If that still isn't helping, then we need to step up into the opioid world. And that's the hydrocodones and the oxycodones. We're going away from the hydrocodone and the oxycodone for long-term pain, because those are short intermittent meds that have to be taken every 4 hours. We're going into our morphine ERs, our oxy CRs. So those are those controlled release medications where they take the med twice a day. And we get that extended coverage on patients for those kinds of things. So we're going more into that field for those people who have that chronic. It also eliminates people from being able to sell them because you can't get an immediate high off of them. So nobody wants them. Okay. And so we're really trying to focus on treating pain and not, we don't want pain to go from high to low to high to low, high to low. We want to be able to control people's pain at a steady level, and that's why we use the ERs and the extended meds. Yep, Joe?
Yeah, I've always wondered about, I think I mentioned this before, I had a back surgery in 97 or 96, somewhere around there. It was a L4-5 laminectomy, and it goes out once in a while. And when I was in Hawaii with my ex-wife, she was stationed over there, they would give me, nothing would work, and finally they used morphine, and that's what took the edge off. But every time I went in, which was every couple of years, I would go in because it would just go out. The pain would be excruciating. It felt like, I don't know, I can't describe it, but it was unbearable pain. But the thing is that when they're basically getting you high, but when I come down, hours later, that's when I get better. My pain starts subsiding. So I've always wondered what that is. Why does that work? Because obviously I probably got some arthritis going on in there, and I probably got some nerve damage around there. Who knows what's going on in there with the laminectomy? And but it always works when they give me those hard drugs and they take it off, and I get pain free for a while. When I'm coming off the pains, I can still feel the throbbing, but that sharp, excruciating, knife stabbing pain is gone. And then I start getting better, and like 2 days later, I'm better. So I never did understand that, why that works.
Well, opioids work because they don't change the pain. They change the perception of pain. So when you get to that point where you're at that high level of it, and when you're starting to come down, that's when the opioid is working, because it's changed your brain's thought process. So when we talk about that perception of the transmission of pain, we're working. Opioids work on that perception. We're changing your perception of pain.
Yeah, I understand that. But I just wondered why, like when the morphine wore off, like the next morning or the next day or whatever, when it wore off, like my pain wasn't as sharp. It's like I don't understand that, because I understand while I am on the drug and it's at its peak level, of course I'm going to be pain free because it's changing my perception of the pain. But my question is, like, when I come down off the drug, my pain is gone. Not totally gone. I can still feel a little throbbing, but like by the next day, I can get up and walk. I can move around.
So
It
tell me,
might have a lasting effect.
what happens?
Yes.
What happens when your pain is at its intense? What does our body do? We talked about our body tries to remove pain, so we tense up, right? And we are all knotted up. And so what happens is that we give that pain med, and it allows the body to relax. And a lot of times those bones can shift and that muscle can shift, and it releases that acute pain process because we've actually been able to relax things enough where the body can begin to take care of itself. So that's why we give people muscle relaxers and those kinds of things, because we're just trying to relax those muscles, because once those muscles tense up around the spinal cord, then it moves those out of place. We need them to relax so everything goes back into its normal positioning. And that's why it probably
Okay,
works like that for you.
Okay, all right, that makes sense. First time it makes sense to me. Nobody explained it to me like that before.
So, so this is the World Health Organization, and this is the pain ladder that everybody should be using. You know, we have to exhaust all efforts before we go to the big guns, okay? Morphine will always be the golden standard of all pain. For every medication that comes out, it will always be measured up to how well morphine covers pain. So morphine is really the big gun. So I've kind of in this, there's the non-opioid analgesics. So there's the salicylates and the non-salicylates. Salicylates are your NSAIDs. So that is your naproxen, your ibuprofen, your Mobic, your Celebrex, those kinds of medications. They inhibit prostaglandins. They inhibit aggregation. We use them to treat mild to moderate pain. We can use them as an antipyretic. So we all know that ibuprofen helps bring fevers down. But they're also for inflammatory. And we use them for a myocardial infarction because we pull our aspirin out, right? And that treats myocardial infarctions, and that's also an NSAID. The adverse effects and why we're going to using more of the naproxens, the Celebrexes, and the Mobics is because those are once or twice a day dosing. Giving NSAIDs frequently increases people's risk for GI bleeds, heartburn, acid reflux, nausea, vomiting, and then, like I said, that GI bleed stuff goes on. So we don't want to use them for people who have bleeding disorders. We don't want to make that blood any thinner than it is, so we don't want to give that. And solicitates need to be used very carefully in people who have kidney failure. Anybody who's got an elevated GFR, really they should not be using NSAIDs any longer. NSAIDs can be very, very toxic to the kidneys. Non-solicitates, these are your aspirins, or this is your acetaminophen or your Tylenol. They have an antipyretic, and we use them a lot for arthritis. So people who have arthritic pain and those kinds of things, we want to use that. The key with a Tylenol is we do not want to exceed 3 grams in a day. More than 3 grams in a day puts people at risk for hepatic failure. It's very hard on the liver. So we used to say it was 4 grams, but now we've gone down to 3 grams. And so the other thing with this that we have to be mindful about is how many meds can you go into. I look at going into, I think about going into my dad's medicine cabinet. Everything he has aspirin in it. So maybe he took a couple 500 milligram tablets of Tylenol for a backache or a headache. And then he has a cold, and so then he grabs Tylenol PM. Well, that's got acetaminophen in there. Doesn't take long for people to add up to that 3 grams without really knowing they're taking it, because Tylenol is added into a lot of things. So we have to be mindful looking at at the ingredients and what is in what, because Tylenol can be added in a lot of things. And so it doesn't take long to get to that 3 grams of stuff. So being very, very careful about that kind of stuff. Opioid analgesics, they bind with pain receptor sites and cause a response, and it changes the perception of pain. We use them for pain or anesthetic. Side effects, things that we have to worry about. It makes people very weak. It can cause headaches. It can cause dizziness. So in your little older people, do you want them on opioids? Probably not. Got to be very careful. The other thing is respiratory rate. It decreases their respiratory drive. So it's not very uncommon at all. You give somebody 4 milligrams of morphine, and they might have been breathing 16 breaths per minute, and they'll drop down to 10. So you have to be careful because that respiratory depression is a big thing. And so just being very careful. But the big thing about it is we can reverse it, right? We give them Narcan, and it reverses the opioids very quickly, and everything comes back to normal. So different things that they're in. So codeine is an opioid, fentanyl, hydromorphone, Demerol, morphine, oxycodone. All of those are opioids, and so we class all of them together. Now, in the opioid field, there's some that are better than others. The codeine and the tramadols, they're your lower level opioids, and then we begin to step up. With morphine and fentanyl being at the top of the um, top of the ladder. I put this slide in because I think it's very, we talk about mixing ibuprofen and Tylenol. So Vicodin is hydrocodone and acetaminophen mixed together. So people who are taking Vicodin, they better not be taking Tylenol in between because they're going to max out on their 3 grams very, very quickly. Percocet is hydrocodone and acetaminophen. Percodan is hydrocodone and aspirin, so that your NSAID kind of sneaks in there. And then Tylenol 3 is your codeine and acetaminophen as well. So people who have acetaminophen, so Vicodin, Percocet, Tylenol 3, they should not be taking intermittent acetaminophen or Tylenol on the side of these meds because they're going to max out very quickly. Opioid antagonist. This is our Narcan or naloxone. This is what's in the news all the time, right? Because cops and EMTs, everybody's got Narcan to give for people who have overdosed on drugs. So what happens is the opioid binds to that pain receptor site and reverses the action of the opioid. And so we use these for people who have overdosed or who have respiratory depression. You give them the Narcan and it will reverse immediately. Like within 30 seconds, it'll reverse it. It can cause diaphoresis. I'm sorry, what?
Did you say Narcan is that fast acting?
Yeah. Yep. Narcan will work immediately. If it is an overdose, they will come out of it with Narcan very, very quickly. Tachycardia, elevation of their blood pressure, tremors, all of those kinds of things can happen because of the Narcan. I had a lady one time who come in and she was buccaling her fentanyl patches, so she cut the patch in half and stick it in her, in between her gums, and she went into respiratory arrest. And I could not get an IV line in to push the Narcan, and so our doctor, he put a central line into her. Didn't even have the central line stitched in. I pushed the Narcan, and she came up off the bed at him and was fighting him to get that out of her chest. That's how quickly Narcan can work. Immediately. Okay, so I think that's all I've got on pain. I do want to go over those questions, okay?
The review questions?
Yep, I want to go over those quick.
Okay.
All right. Okay. So the first question is, a nurse is assessing the pain level of a client who's come to the emergency room reporting severe abdominal pain. The nurse asks the client whether he has nausea and has been vomiting. The nurse is assessing for which of the following?
A.
Why do you pick A, Kobe?
Because along with pain can come, like, those are some side effects of it that can come along with it.
Absolutely. Absolutely. So the nausea and the vomiting, those are associated symptoms. And so, diaphoresis would be an associated symptom. Lightheadedness, dizziness, those kinds of things would all be associated symptoms. Second question. A nurse is assessing a client who is reporting pain despite analgesia. The nurse can best assess the intensity of a client's pain by asking what precipitates the pain, questioning the client about the location of pain, offering the client a pain scale to measure the pain, or use open-ended questions to identify the sensation.
Offering the client a pain scale to measure his pain.
Absolutely, because remember the question says you are measuring intensity. Okay?
Right.
Intensity is measured 1 to 10. How bad is it? So pain scales measure intensity of pain. A nurse is obtaining a history from a client who has pain. The nurse's guiding principle throughout the process should be: some clients exaggerate their pain level. Pain must have an identifiable source to justify the use of opioids. Objective data are essential in assessing pain, and pain is whatever the patient says it is.
D.
Yep. Okay. Because we talked about the fact that there is idiopathic pain, which is it's not identifiable, right? So it would be unjustifiable for us to not treat that pain. We can't put a finger on what it is, but it's still real. So, B is out. We know that objective data really isn't good. We try to put pain scales on it, but it really doesn't help us a whole lot. So it's all subjective. Oops. A nurse is monitoring a client who is receiving opioid analgesia for adverse effects of the medication. Which of the following effects should the nurse anticipate? Select all that apply. Urinary incontinence, diarrhea, bradypnea, orthostatic hypotension, or nausea.
B, D, E.
B, D.
All of them except for A.
Yeah, I would say all of them except A.
Yep, because bradypnea, that's that slow respirations. So you can get tachypnea or bradypnea, and so bradypnea is the slow respirations, and we know that opioids can do that. Which of the following signs or symptoms in a patient who is opioid naive is the greatest concern to the nurse when assessing the patient 1 hour after administering an opioid? Oxygen saturation of 95, difficulty arousing the patient, respiratory rate of 10, or pain intensity rating 5 on a scale of 0 to 10.
E.
Everybody agree?
Difficult.
C.
Okay. Now, this is one of those questions where there's more than one that is right? But this is one of them that you have to go back and apply your ABCs: airway, breathing, circulation. Those will always be your answers. When you have more than one right answer, you go back to ABC. And so therefore your answer is C, breaths of 10 per minute, because you've changed that respiratory rate. Okay? Oh. A patient is being discharged home on around-the-clock opioid for chronic back pain. Because of this order, the nurse anticipates an order for which of the class of medications: an opioid antagonist, an antiemetic, stool softeners, or muscle relaxants.
Muscle relaxants.
Stool softeners.
I would say D, muscle relaxer.
The answer is stool softeners.
Really?
Opioids slow down the peristalsis of the stomach. So anybody who is using chronic opioid use, they will always have constipation. So
Yeah.
anybody who's on opioids should be on a stool softener, because they will get constipated. And it's just because opioids slow the peristalsis down. So making sure that somebody's on a stool softener all the time with that. So something to be careful about with those. All right. You guys did good. You did good. It's important to be able to talk through those and kind of work through those. I think that's so important to be able to kind of get the gist of things, okay? Questions regarding pain?
I have a little trouble with the whole opioid type. I mean, I get it to an extent, but there's, I guess, some things I just don't get.
As Like what? Tell me what you, give me a specific.
Like the different meds that are opioids and
Okay.
non-opioids.
So a non-opioid would be it's either a salicylic or a non-salicylic. So that's your NSAIDs, which are salicylics, or Tylenol or acetaminophen. Okay, those are your
Oh,
non-opioid medications. Opioid
okay.
medications are everything else. So
Okay.
codeine, tramadol, oxy, hydros, fentanyl, morphine, all of those are all opioids. But now in the opioids, you have to remember that you also have a ladder of opioids. So Tylenol or like codeine and tramadol would be at the lower level, whereas your morphines and your fentanyls would be your higher level medications. And so
Okay.
those are the differences of that. So if you look back on the medication part of this slide, Kobe, it talks about the difference of the non-opioid versus the opioid meds. But the only ones we have for non-opioids um, are the Tylenol and NSAIDs. Now you can throw muscle relaxants in there. You can throw probably gabapentin and Lyrica in there as well. I did not put those meds in because those, we'll talk about those when we get to the neurological side of things. But Lyrica and gabapentin, how they help with pain is they work on the neuropathic pain. So people who have neuropathic pain should be on a gabapentin or a Lyrica. You know, people who talk about numbness and tingling in their fingers or in their feet or their hands. Because what has happened for most of those people, it means that there's a compression on the spinal cord, so compression of the nerve, and so they get that neuropathic radiating pain. And so those people should be on a gabapentin or a Lyrica, and that will help with the neuropathic portion of the pain. Where like your Celebrexes and your ibuprofens and those kinds of things, they work on the inflammatory component of the pain. And then your muscle relaxants are very helpful, especially with people who have chronic low back pain, because a lot of times those muscles have contracted around that spinal cord, and muscle relaxants will just kind of release that muscle so that that spine can go back into normal alignment. Okay.
Right. And my grandma takes gabapentin for diabetic nerve pain at night.
Absolutely.
So
Yep, yep. And gabapentin is a great med. Some people don't tolerate gabapentin very well. And so, you know, a lot of people get really tired from gabapentin and those kinds of things. But we always try gabapentin before we go to Lyrica. And the reason being is gabapentin, one pill of gabapentin costs 23 cents. A pill of Lyrica costs $2.80. So that's why we
ooh,
use gabapentin first. If people can use it
yeah.
and it gives them pain relief, we use the gabapentin. If we have to go to the Lyrica, we'll go. There's just such a cost difference, and that's just because Lyrica has not become a generic yet. When Lyrica becomes generic, you'll see that begin to change, but we're just not there yet. Okay.
Other than that, I'm good.
All right. Reggie, any questions? Joe, any questions?
No, no, I don't have any questions.
Okay. All right. So if you guys have questions or concerns, let me know. I probably will not get next week's PowerPoints out to you until Sunday. But I'll get them
Okay.
done as soon as I get them done. With the holiday weekend, things are kind of crazy around here, but I will get them out to you on Sunday then. Okay. All right.
Okay.
Otherwise, everybody have a great Labor Day weekend. And if you have questions, please let me know. Okay. All right.
You too.
Good night.
Oh,
Yeah.
Yeah.
did you mention anything about anesthesia? Or are we going over that next class?
There is actually in a couple weeks we'll talk more about surgical care, and I'll talk about anesthesia when we get into that area. Okay,
Okay.
so
All right.
you will have no testing over anesthesia on this test. In a couple weeks we'll go over post-operative care, and I'll cover it then. Good question.
Okay.
Okay.
All
All
right.
right. Have a great night, everybody.
Yeah.
You too.